Thanks, Ed. Good morning, everybody. Welcome to day two. It's going to be a great schedule today, as Ed was saying. Our first panelists that have a great discussion from the CDC, Dr. Douglas Roehler is an epidemiologist with the Center for Disease Control. He specifically is assigned to the Cannabis Strategy Unit, expanding research surveillance systems associated specific to cannabis. He's got an extensive background in research. His prior experience does with overdose morbidity. He was with that team, enhanced non-fatal overdose data at the same time. He is published many times over. So I'll tell you what, I've listened to Doug before. You guys are in for a great treat. So with that, Doug, I'll turn it over to you and sit back and be educated with everybody else.
Great, thank you so much, and it's so nice to see you. Hi everyone, my name is Doug Roehler. I am, as just learned, an epidemiologist in the Cannabis Strategy Unit here at CDC. This Cannabis Strategy Unit sits within the Division of Overdose Prevention, which is part of the National Center for Injury Prevention and Control. Today's talk, I'm going to share a little bit about the Cannabis Strategy Unit, just an overview, give you an idea of some of the work that is going on in the CSU, as well as some of our previous work. And then I'm going to share some highlights of a study that I published over this past summer. Standard disclaimer, the findings and conclusions in this presentation are those of me and do not necessarily represent the official position of the CDC. So here's the CDC strategic plan, just a broad overview. In late 2019, there was some strategic restructuring related to the cannabis work at CDC. Prior to 2019, there was a little bit of cannabis work going on across all different parts of CDC. So there was some work going on in the Office of Smoking and Health. There was some work going on in the Division of Overdose Prevention, labs, birth defects, etc. We realized that given the increasing legalization across the country, CDC needed to have a more cohesive, comprehensive, unified message. So we stood up the Cannabis Strategy Unit. The primary goal of the Cannabis Strategy Unit is to monitor and address use of and exposure to cannabis, so including marijuana and hemp, THC, CBD, and Delta-8, and all these new cannabinoids, and to learn more about the associated health effects. After reviewing the literature and consulting with experts from across the country, we came up with these 6 pillars of the strategic plan. And I'll go through each of these pillars and talk a little bit about some of the work that we're doing. Overall, the goal of the CSU is to learn more about health and social effects of cannabis use. Focus areas include cannabis initiation and use, substance use disorder, poisonings, occupational injury, motor vehicle crashes, employment, although most of the employment work is done by a different part of CDC, which is NIOSH. We'll learn more about developmental outcomes and prenatal and pregnancy complications. We focus here in the Cannabis Strategy Unit with what CDC is best known for. That's our surveillance work, our capacity building, technical assistance, and applied research. It's important that the work that we do here at CDC related to cannabis is complementary to and collaborative with other federal agencies, and it's not redundant. And I'll talk a little bit more about that in just a second. We have some populations of interest where we really try to focus our efforts. Those include adolescents and young adults, older adults, infants and young children, pregnant and postpartum persons, workers, racial and ethnic minorities, and then those in poor health and with chronic conditions. So the first pillar that I'm going to discuss today is building state, tribal, local, and territorial capacity. CDC, or the Cannabis Strategy Unit at CDC, we sort of have this unofficial role of being the coordinating agency for the cannabis work across the federal government. So there's a lot of cannabis work going on at NIH, DEA, FDA, etc. So in May of 2021 and in May of 2022, CDC, along with the American Public Health Association, so APHA, we sponsored 2 meetings. The first meeting in 2021 was in Washington, D.C., and we invited national partners and federal agencies who are doing work in the cannabis space. And Dale was at that meeting. So HIDA was represented. And we had the overall goal at this meeting to learn what other federal agencies and national partners are doing in the cannabis space. And we wanted to develop a strategic plan for the federal government and to identify areas for collaboration. And then in 2022, we had a similar meeting, but this time we only invited other federal agencies that were working in the cannabis space. And again, to learn more about opportunities for collaboration, and to also identify where does more work need to be done in the cannabis space? What are the gaps? So the Cannabis Strategy Unit, we hold monthly or bi-monthly, I believe, coordinating calls with other federal agencies. So another activity that we have in this space is we've been working with the National Conference of State Legislatures to develop a case report on how other states have legalized cannabis. So what's the history of from the very beginning of when efforts were starting in terms of legalization to today, and how have policies changed for each state. So this comprehensive report can be found on the NCSL website. And the last activity, and these activities are not comprehensive. I'm just picking up I'm just focusing on the highlights. We're working on a resource for action for youth substance use prevention. So this resource will be published next year, and it highlights evidence-based youth substance use intervention strategies and approaches. So this will be a document that our local and state partners could use if they identify that youth substance use is a problem in their community, and what are some ways that we know are effective at addressing youth substance use prevention. Next pillar is supporting health systems and providers. So in September of 2021, we released a health advisory network health alert on the dangers of Delta 8 THC. September 2021, it doesn't seem that long ago, but Delta 8 was sort of just now, at that point, was just starting to hit marketplaces. We didn't really know too much about it, but we released this ton to make the nation aware of the potential dangers of Delta 8. We've also been working with the National Council for Mental Wellbeing to develop a toolkit for youth substance use prevention. It's called Getting Candid, and that can be found on the National Council website. And the focus of this toolkit is for how youth serving providers can communicate with youth about their substance use behaviors. It's full of different resources about how to do motivational interviewing, how to use social media for messaging. It's quite comprehensive. So it's called Getting Candid, CANDID, and that can again be found on the National Council for Mental Wellbeing's website. And the third activity that we have in this space is we're developing fact sheets for medical providers related to cannabis, and specifically the relationship between cannabis and chronic pain. In terms of the partnering with public safety schools and community coalitions strategic pillar, we provide technical assistance to drug-free communities. Drug-free communities, the program lives within the Division of Overdose Prevention. We provide funding to over, I think, 700 different local coalitions. They have to focus, with their funding, they need to focus on youth substance use prevention in some capacity. So in the Cannabis Strategy Unit, we hold a lot of Cannabis 101 talks with local organizations. They come to us with questions about, they're seeing cannabis in their youth using cannabis in their communities. What can they do? So the Youth Substance Use Prevention Resource for Action is developed really with drug-free communities in mind, so that when they apply for funding, it would be quite simple for them to pick out different evidence-based interventions and implement them in their communities. The fifth pillar is to increase public awareness. One activity that we've actually been spending quite a bit of time on is updating the CDC marijuana website and fact sheets. As you all know, our knowledge of cannabis and health effects, different products, and the dangers of just different products, it evolves every day. Every day is different. So we spend a lot of time updating the website so that the CDC website can serve as a reliable resource for families, organizations, communities, so what they can go to if they have questions related to cannabis. We also spend time answering public inquiries. So anybody can email CDC about really any health topic, but if it's related to cannabis, it comes to us and we spend time providing thoughtful responses. So actually, this is the fifth pillar. The last one is the fourth pillar. So for the fifth pillar, monitoring trends. Again, this is sort of bread and butter CDC. We have, for the past 2 years, we have provided funding to states to incentivize them to implement the BRFSS, so Behavior Risk Factor Surveillance Survey. Surveillance survey. The optional marijuana module. So the marijuana module, I think it has about 7 different questions, and it asks about not only use, but how are you using it? Are you dabbing? Are you eating it or drinking it, or are you smoking, etc.? So I think each of the past 2 years, we've been able to provide funding for up to 14 states to implement the marijuana optional module. So this is a way for us to get, and we select the states based on have they implemented it previously, and if they haven't, then you have a much greater chance of being funded from us. So we're trying to get a national picture of cannabis use across the country. We've also have spent quite a bit of time and money cognitively testing cannabis questions that can be implemented on national level surveys. We're trying to really figure out how to differentiate between hemp-derived products so the Delta 8s, the Delta 10s, and marijuana, so Delta 9 and CBD. So we're spending a lot of time cognitively testing different prompts and different questions to hopefully land on some language that can really help us answer some of these questions and get a better understanding of what does use look like for these different products. And lastly, this is exploring marijuana supplement in PRAMS. So PRAMS is a pregnancy risk assessment monitoring system. So it's a survey that is only sent to pregnant persons or folks that recently had a baby. And we're working on a study now about marijuana use during pregnancy and why they've used it. And we're also looking at a study on the health effects of marijuana use during pregnancy on the baby after the baby was born. And then the last strategic pillar we have here is advancing research. So one big project that we're currently working on is we're funding a special supplement on cannabis for the American Journal of Public Health, which is the journal associated with the American Public Health Association. So we are funding The supplement, it's called Emerging Issues in Cannabis Surveillance and Applied Research. I am a guest editor along with my colleague, Dr. Brooke Hoots, and this will be published in October of 2024. So I think there are about just under 10 articles that will be included, and we're going through the peer review process right now. And then the final activity that I'll mention here is we published over the summer in an MMWR on cannabis-involved emergency department visits among youth. And we look at cannabis-involved emergency department visits before COVID and then during COVID. So, and that's the study that I'm going to introduce you to right now. So here is, here's just the title. It was published in July 14th of this past year. Here's the link, but you can easily find it by just typing into Google or whatever you use, MMWR cannabis. Okay, I'm going to talk a little bit about background of cannabis, but I know that this is not new information for any of you, so I apologize. I'm just trying to do some level setting here. So over the past 27 years, access to cannabis has increased dramatically across the United States. California was the first to legalize marijuana in 1996. We know that perception of risk associated with cannabis use has been declining, both for adults and for youth. And we know that the COVID-19 pandemic was linked or has been linked to increased substance use for youth, especially those youth with pre-existing mental health conditions. Yesterday, the Substance Abuse and Mental Health Service Administration, so SAMHSA, they released findings from the National Survey on Drug Use and Health, which is called NSDUH, from 2022. And then according to NSDUH, the 6.4% of teens aged 12 to 17 reported using marijuana in the past month. So it's 6.4%. And this is actually up from the prior year when it was at 6.1%. So it has increased in 2021 from 6.1% into 2022 to 6.7%. This is still down from 2019 when we were at 7.4%. But I think it's important to point out here, related to this study, that, well, we know that use is increasing, but just because use is increasing, it doesn't necessarily reflect how the products are changing. So the products are changing, as you know, by becoming more and more concentrated with THC. We don't know the long-term health effects of this. We don't know too much about what folks are using, how they're using it. But this study here focuses on cannabis-involved ED visits, emergency department visits. So what does it look like from at the national level of youth who are showing up to emergency departments and they tell the medical provider, I'm here and I have, for whatever reason, but I also have been using cannabis or have a history of cannabis use. So this study sort of gets at a little bit, how are these products changing and how does that relate to health outcomes? Here's just a timeline that just highlights how dramatically the landscape has been changing since 1996. Again, 1996 was when California legalized for medical purposes. Yeah, and so it's very very dense down here as we get more recent. What's not included in this picture is Kentucky, which legalized for medical purposes in 2023, and Delaware and Minnesota, which legalized for non-medical adult use in 2023. And then also, what's not reflected on here is Ohio, which legalized for non-medical adult use, which will start and sales will start in Ohio by the end of 2024. I think Ohio is it's going to be very interesting to see what happens because Ohio is a big, increasingly red state, and it will be interesting to see if other red states start to follow the lead of Ohio. So since 1996, medical use of cannabis has been legalized in some capacity in 40 states and Washington, D.C., and non-medical adult use of cannabis has been legalized in 23 states in D.C., or I guess 24 states now because of Ohio. So methods. So for this study, we analyzed emergency department data from the National Syndromic Surveillance Program. So syndromic surveillance, these data are reported in nearly real time to NSSP. And these are emergency department visits, and they include chief complaint and discharge diagnosis. So chief complaint, it's text-based. So what is the patient saying for the reason why they're there to the medical provider? So one example might be, I smoked a joint and I fell off my bike, for example. That would be a situation where they would be captured into our study. And then these are the discharge diagnosis that were evaluated. So these are the ICD-10 CM codes that we included in our study. We measure changes in cannabis-involved ED visits among those under 25 years through the mean weekly number of cannabis-involved visits, rates of cannabis-involved ED visits, the overall visit ratio, and visit ratios by sex. And visit ratios are calculated by dividing the rate of cannabis-involved ED visits during the surveillance period by the rate of cannabis-involved ED visits during the reference period. So the reference period here would be 2019, so just before COVID. And if you have a rate of 1 or higher, it indicates higher rates of cannabis-related ED visits during the surveillance period compared to the reference period. Here are all the different surveillance windows. So we broke the calendar into 4 different periods. And these are the surveillance periods for 2019, 2020, 21, and 2022. The first one is yellow here. And this is, we call this pre-pandemic. So if you're looking at 2020, we know that COVID was around, but the public health emergency wasn't officially declared until mid-March. So we call this pre-pandemic. Surveillance window 2 is green, and this would be the second half of the school year. So after winter break, students are coming back. So this is the second half of the school year, roughly. And then this orangish reddish color, salmon color, I guess, this would be considered summer. And then blue is the first half of the school year. So just to backtrack a little bit, we compare like each of these surveillance windows between each of the years. So we compare like the summer in 2019 to 2020. We compare the summer to 2020 to 2021 and 2021 to 2022. And we also compare them to the reference period for before COVID. Some of the findings. So we broke the group, or we broke youth into 4 different age groups. So 0 to 10, 11 to 14, 15 to 24. And then those, just 3 different groups, 0 to 10, 11 to 14, and 15 to 24. And for each of those 3 age groups, across the duration of the study, cannabis-involved emergency department visits were higher during COVID than compared to 2019. Another a really interesting finding is for those under the ages of 10, so 0 to 10 or 0 to 9, cannabis involved emergency department visits were dramatically higher during COVID compared to before COVID. We'll talk a little bit more about that in a second. And then thirdly, visit ratios by sex did not differ among children in the 11 to 14 age group early in the pandemic, but it's, and I'll show you a graph in a second, but starting early in the pandemic, we see this flip in terms of cannabis involved EVD visits by sex. So prior to the pandemic, males had a higher, in this age group, 11 to 14, males had a higher rate of emergency department visits or cannabis involved emergency department visits. But then early in the pandemic, we see this switch and females suddenly have a higher rate of cannabis involved emergency department visits. And this flip stays that way throughout 2022. So here's 0 to 10. This is roughly where I'm not sure if you all can see my cursor or not. I think you can. But in this first box, 0 to 10-year-olds, we see this massive spike, and it stays elevated. So this is showing that among 0 to 10-year-olds, cannabis involved emergency department visits were elevated during the pandemic and remained elevated. If you're looking at 20 or 11 to 14-year-olds, you see the bluish purplish line is males and the black is females. You see it early on, roughly the equivalent, but then during the pandemic, we see this switch and females suddenly have higher rates of cannabis involved emergency department visits. And then 15 to 24-year-olds, this is where most of the cases fall in. And we see that during the pandemic, rates were elevated for cannabis involved visits. And then at the end of 2022, we start to see rates come back down to what they were prior to the pandemic. Still elevated, but much closer to baseline. And then the fourth box is just overall. Here's just a graphic that the MMWR office made for us. It highlights that cannabis involved emergency department visits increased for those under the age of 25 during the COVID-19 pandemic. I just want to backtrack 1 second here, because it's also important to highlight that 90% of cannabis involved ED visits occurred for those aged 15 to 24. So again, 15 to 24-year-olds, this is where we're seeing most of the cases. But it's really important to break them apart by age group, because we're seeing for those under the ages of 10, we're seeing much higher rates during COVID compared to before COVID. So what are the implications? I think one of the most important implications is keeping cannabis products stored in a locked container out of reach of children. So this really speaks to the finding of 0 to 10-year-olds are seeing much higher rates of cannabis involved visits. We know that 0 to 10-year-olds are not smoking the product. They're not intentionally using the product. So this means they're in most, we don't know for sure because of the level of data that we have access to, but we suspect these are unintentional cannabis ingestions. We know that companies or businesses are trying everything possible to make cannabis products, especially edibles, resemble common candies. They're directly appealing to youth. We recently published a case study that looked at two sisters who were admitted to the pediatric ICU here in Atlanta because they got into their parents' Delta-8 THC nerd ropes because they thought that it was just candy. I put them both into the PICU. Luckily, both of them were just fine, but it's a great example of we need better packaging, we need more restrictions on labeling and marketing, and we need to figure out how to get these lock boxes into parents' hands for those who use cannabis. Similar to gun storage boxes or prescription drug lock boxes. Secondly, one of the implications is implementing evidence-based youth substance use prevention strategies in communities. As the THC concentration of these products continuing to increase, as more and more states legalize, it's becoming easier to access cannabis products for youth. So it's essential for us to implement not just youth substance use interventions, but importantly, evidence-based youth substance use interventions. So we're working with drug-free communities on this, and we've been partnering with state and local health departments. And then lastly, and I spoke to this earlier, but it's really important for states to implement and strengthen packaging restrictions to decrease appeal to youth. So I think the Western states are doing a pretty decent job at this, but there's always room for improvements. Just some limitations to the study. So our syndromic surveillance data are not nationally representative. However, we do NSSP, so the surveillance system, they receive medical data from approximately 75% of emergency department visits, or 75% of emergency departments across the country, including DC and Guam. Next, there are different coding practices and changes in emergency care, and there are fluctuations in the number of emergency departments participating in NSFT. So our data might overestimate or underestimate the true emergency department visits, but I think it's important to note that the trends will stay true regardless of emergency departments opting in and out of the system. And although multiple visits by the same patient, there may be multiple visits by the same patient, and we don't know the intent of cannabis use, but again, the data clearly illustrate patterns in cannabis-involved emergency department visits. And lastly, I'm actually in Atlanta today. I had to come into Atlanta this week, but I live full-time in San Diego. I work 100% remotely from San Diego for the CDC. So with that being said, I would love to meet some of you in person. I'd love to see offices, learn more about the work that you all are doing in the Western states. So please feel free to reach out to me. You can email this email address here, or just Google me and you can get to me pretty easily. So with that being said, thank you so much for inviting me to present today. And again, I look forward to hopefully meeting some of you in person in the near future.
Oh, great job, buddy.
Thanks.
If you folks would like to take a look at that report and see it in its detail, if you go out to our website, the NMI, right under where it's emerging threats and health information, scroll down there, you'll find the report that Doug was referencing. But Doug, I'm going to put you on the spot real quick. You and I are getting into an elevator. I find out that you're working for CDC and you're working in the Cannabis Project. I'm getting off on the 9th floor. What do you want me to know in that elevator pitch?
I want you to know that I think there is so much work that needs to be done in this space. We know that CBD use is increasing across the nation. We know that people are using CBD for every sort of health ailment. and the data are not supportive. We don't have the data on the effectiveness of CBD. We know that CBD can interact with other drugs that you might be taking, and we know that it can cause harm. But I think that a lot of the CBD use is placebo effect. But I think it's really important. And the other important thing about CBD is it's very rarely just CBD. It's not regulated, so often THC is actually in these CBD products, and that's scary because if you are taking these products and you get behind the wheel of a car and you happen to have a CBD product that has higher THC, then you become a danger not only to yourself but to the others on the road. So there's a lot of work that needs to be done in this space. We're a very small team, but we are doing everything possible and collaborating with folks across the nation in this space in order for us to have a safer, a safer environment when it comes to cannabis.
With the overall reduction in the perception of risk of harm, where are we missing the opportunity here to get that message out? Not only just to the kids, but we're seeing so many reinitiations and first-time initiations with the younger adults. How do we get that message across that this is not a harmless, benign drug that everyone wants to think that it is? How do we do that one?
So I think it can start with our medical providers. We know that medical providers, we've done some studies on this. Oftentimes they don't know what the legal status is of their state. And I was talking with a cancer doc the other day, or an oncologist, and she's like, we don't know if this stuff works, but we know that the patients like using it. So what I just tell my patients, if you want to use it, you can use it. And I don't think that's necessarily the best message. We look to medical providers as, appropriately, we look to them to provide us with the best possible information on these products. And we need to work with them to make sure that we have, a level knowledge base and consistent knowledge base about the potential harms of these products.
And that's one of the things that I think you're striking on that I don't think a lot of people realize is that there is so much, going back to what we said yesterday, misinformation, disinformation about this particular drug and the cannabinoids associated to it, that it's really hard for the average person, let alone a provider, to get good solid information to understand all the drug interactions, the health interactions. So I think you've identified a huge gap in the educational circle there. Tell you what, folks, if you got any questions for Doug, we've got just about a minute or two here left over before we segue to the next section. But Doug, as always, great session, great information. The work that you guys do at CDC is phenomenal, and you're a good partner in crime to have. So with that in mind, I'll tell you what, we'll wrap up. If you got any closing statements or thoughts you'd like to throw out there, Doug, I'll give you 30 seconds to a minute. It's all yours.
Thanks again. It's always great seeing you. Please don't hesitate to reach out to us. We're, part of our job here is to provide technical assistance to state and local partners. And we are here to be a resource for you all. So if we can't help you, we can certainly connect you with folks that can.